Hi, thank you for joining me today. I'm Sarah Brennenstuhl, and I'm reporting on a paper called the Comparative Study of Socioeconomic Inequalities in Health Among Mothers of Young Children. This is actually part of a larger project looking at socioeconomic inequalities in health among women more generally. If you are interested in this topic, I'm happy to talk to you more about it afterwards. Before I move on, I'll acknowledge my co-authors, Diana Wartz, Vincent Hildebrand, Arjuman Siddiqui, and Peggy McDonough. And we're all at the University of Toronto at the Dalla School of Public Health. Okay, right. All right, so this presentation focuses on mothers of young children. This topic has a particular relevance to me as I just recently became a mother myself for the first time, and I feel very privileged to be able to receive or to be able to spend a year with my son while receiving maternity benefits, as well as having access to a second income provided by my partner. But I know not all mothers are as well protected, and having fewer resources is likely related to poorer health. So what do we know about mothers and socioeconomic inequalities in health? Well, probably not a lot, actually. We know a little bit about the health status of mothers. We know that mothers tend to have a health advantage over women that aren't mothers, but that this advantage quickly turns into a disadvantage when the total workload, which includes work at home and employment, becomes too high. We also know that some types of mothers are worse off than others. For example, single mothers have poorer health than mothers that are partnered and are more likely to be impoverished. Feminist research also provides us with some insights about the well-being of mothers, although without an explicit focus on health. Feminists has long claimed that social policies surrounding the integration of employment and family life are critical for equalizing the opportunities of mothers of young children. So important social policies in this regard include childcare, care leaves, and other forms of income support. So feminist welfare state theory is a particularly useful framework for understanding the relationship between social policies and mothers' well-being. So feminist welfare state theory focuses on how social policies influence women's organization of family and employment roles. So James Lewis typology, which is shown here, differentiates welfare states according to the extent to which social policies reproduce gender norms that prescribe breadwinning for men and caring or homemaking for women. So she argues that in strong male breadwinner states, such as Britain and Germany, caregiving has been treated as a private activity, and there have been relatively few public childcare options, especially for younger children. So as a result, mothers' overall labor market participation is relatively low. In modified male breadwinner states, which include France, motherhood has traditionally been treated as a social function rather than as a private matter. And as a consequence, full-time labor market participation has been higher than in strong male breadwinner states. And this is facilitated by social policies such as universal child care. However, private forms of caregiving are also supported, and this is evidenced by a 3-year parental leave program that has been available in France. This care leave encourages some mothers to stay out of the labor market for longer periods of time. Weak male breadwinner states include Denmark, where a dual breadwinner family model has been emphasized since the 1960s. In Denmark, the state has a large responsibility for caregiving as reflected by the high availability of public childcare options, which in turn support a high level of women's labor market involvement. So despite the knowledge that social policies affect the well-being of mothers, the extent to which these policies influence inequality in mothers' health remains largely unknown. It is speculated that the relationship between socioeconomic position and mothers' health may be weaker in social policy contexts where mothers have more access to paid work and therefore more access to income. One way to test this speculation is to compare the size of socioeconomic inequalities in health across countries that differ in their approach to the organization of women's employment and family roles. Using longitudinal data will also be useful to gain insights about health over time. It is suspected that mothers with fewer socioeconomic resources will not only have worse health, but will also experience a faster rate of health decline. So the goal of this research is to use feminist welfare state theory to examine socioeconomic inequalities in health dynamics among mothers of young children in countries that differ in their approach to the organization of women's employment and family roles. So we hypothesize that socioeconomic inequalities in mothers' health dynamics will be largest where social policies encourage mothers to be unpaid caregivers, and this is in the strong male breadwinner states of Britain and Germany. The inequalities will be smallest where social policies support mothers as paid workers in Denmark, and intermediate where social policies are more mixed surrounding employment and family roles, and this is an example, France. So the data from our research were derived from the European Community Household Panel, and this ran from 1994 to 2001. The analytic sample for the study was based on working-age mothers of young children from Britain, Germany, France, and Denmark. So mothers of young children were defined as women living with children under 12 for the majority of the waves of the survey. There was actually no question, are you a mother or not? So this was kind of our way of dealing with that issue. So the outcome measure was self-rated health, using the question, how is your health rated in general? Based on the response options were based on a 5-point scale ranging from very good to very poor. Socioeconomic position was measured by highest level of education, and this was categorized into 3 levels, high, medium, and low. We used several control variables, both time varying and time invariant. The time varying include employment status, marital status, and household income, and our invariant ones included age and birth cohort. And then finally, the analysis it was done using latent growth curve models. Okay, so here's a simplified version of the model used for the analysis. So in latent growth curve modeling, each individual is assumed to have her own latent trajectory, which is characterized by an intercept and a slope, the I and the S in the diagram here. In this case, the intercept represents initial health status and the slope represents health change. So individual health trajectories are combined to estimate the mean latent trajectory, which best fits the repeated measures across all the individuals. You can then introduce variables into the model to predict differences in individual health trajectories. So in this study, we introduced education level as the main predictor. And like I said, we controlled for age cohort, marital status, employment, and income as well. So initial testing determined that self-rated health could be modeled as a continuous variable, and that the data in the model for health change could be represented by a single linear slope. So I'm just going to give you a quick overview of the analyses. So first, we modeled the relationship between socioeconomic position and health using the latent growth curve model that I just described. Next, using the estimates from the final models, we compared the size of socioeconomic inequalities in health across countries using Z-scores. And then finally, we compared these findings with results based on a larger study using a similar methodology focusing on all women. Okay, there we go. All right, so moving to the results. So we found that education predicts worse health, initial health, thank you, among mothers of young children in all the countries except for Germany, where it is instead marginally associated with health decline. So low education is also marginally associated with health decline in Denmark, and there are no differences in the health of mothers with high and medium level education in any of the countries. So to visualize the effect of education on health over time, we plotted mean self-rated health for each year in each country, controlling for age and birth cohort. So as shown here, you can see there's a noticeable, see if I can do it, a noticeable difference between the health trajectories defined by low education, and that's the green dotted line, and high education, which is a solid blue line at the top in all the countries, except for Germany, where this difference only really emerges over time. And you see it emerging over time a little bit in Denmark, too. There's very little difference between the health trajectories of women with medium-level education and high-level education in any country. You can see that here, maybe a little bit over time in Germany, but that's not significant. So what this says is really that mothers with low education are particularly vulnerable to poor health. Okay, so next we move on to comparison of the magnitude of educational inequalities in health across countries. And we compared only initial health, of course, because health change wasn't significant, or was only marginally significant. So against expectations, there were no cross-national differences in educational inequalities in health. So you can see that clearly here, that there's really no difference. However, okay, so next we compare the results of mothers of young children with all women. With the exception of Britain, the effect of low education on initial health is actually smaller among mothers. And interestingly, the extent to which this is the case is at least partially consistent with expectations based on feminist welfare state theory. So in Denmark, the coefficient for low education is actually 44% smaller among mothers and all women. In Germany, this is 34% lower. In France, it's 8% lower. In Britain, by contrast, the coefficient for low education was actually 9% higher among mothers, right there. So these findings suggest that Danish social policies, such as universal childcare, may be most effective for mitigating educational inequalities in health among mothers of young children compared to all women. And this is consistent with what feminist welfare state theory would say. So while the results for Denmark and Britain in particular are highly consistent with feminist welfare state theory, those for France and Germany are less so because of the much larger reduction in socioeconomic inequalities in health among mothers compared to all women in Germany compared to France. So when trying to figure out why this may be the case, it's important to consider that a much smaller share of women are mothers in Germany than in the other countries studied. In fact, during the study period, Germany had among the lowest fertility rates in Europe. And the low birth rates in Germany may reflect more traditional attitudes towards child rearing. And related to that, the lack of policies supporting the integration of employment and family, such as few public child care options for very young children. So against this background, it is expected that career-oriented women may be less likely, more likely to remain childless in Germany, thereby reducing overall levels of fertility. So to put it differently, it may be that motherhood is more attracted to women with lower career aspirations, or those who are unable to work and thus have less need for educational credentials to gain access to the best jobs. So in short, social policies may affect the size of socioeconomic inequalities in health, but they also may affect the socioeconomic profile of the women who actually become mothers. So moving on to some conclusions. So this study reveals that socioeconomic inequalities in health exist among mothers of young children in all the countries studies, although only, some only emerge over time in the case of Germany. Against expectations, there are no differences in the size of inequalities among mothers across the countries investigated here, and also within the time period investigated here. So we know that family policies have changed quite a bit in Europe since the early 2000s, so it would be interesting and important to kind of look at this in a more recent data set. Consistent with what we would expect based on feminist welfare state theory, we see that Denmark appears to be the best at minimizing vulnerabilities related to being a mother of a young child compared to all women. And the knowledge that the health of mothers of young children is sensitive to more generous policy arrangements should be heeded by policymakers, especially in those nations falling behind in the provision of universal daycare systems, which includes most parts of Canada. So finally, this study suggests that feminist welfare state theory may be a useful tool for understanding mothers' health, and that this model should be tested in further research. Speaking of further research, and given that we are here in Quebec, I suggest it would be valuable to study this topic in the Canadian context, as the different provinces provide different levels of support to mothers. So a new report from the Canadian Centre of Policy Alternatives suggests that women in cities from Quebec fare better than the women from the rest of Canada. And this is in large part due to women's higher level of access to full-time employment. So whether this is also true that the gap between mothers of young children who are in lower and higher socioeconomic group is also smaller in Quebec compared to the other provinces is not yet known, but this would be an interesting project. And I'll leave you with this idea in your mind. Thank you.